Okay. Well, it's great to talk with Lauren Stiles. Lauren was the is the founder of Dysautonomia International. She founded it, I think it was 12 years ago. And boy, what a moment that was. I don't believe there are any nonprofit groups focused on dysautonomia before Dysautonomia International. And boy, I was just shocked at how quickly it took off. Which I guess is really not a surprise, given that dysautonomia features in so many illnesses, particularly illnesses, some of the illnesses that the ME/CFS and fibromyalgia communities are interested in. There's ME/CFS, there's fibromyalgia, of course, there's POTS, there's long COVID, and it really, I don't think it was really given its due for a long time, and it probably still hasn't been given its due. But Dysautonomia International really struck a chord, and they've been putting on international conferences. They've been funding research. They are great at patient support. They have this nifty map, which I love, of dysautonomia experts, and they are not easy to find.
Mm.
So it's really great to talk with Lauren about this really important subject that she's so immersed in. That's an important subject for us all. So, but first, I just wanted to, Lauren has such an interesting illness story. I wonder if you could just
Mm.
quickly go over. It's really illustrated. I think it's really illustrative of the things that many people go through, because it was not an easy. She's not having an easy time of finding out what she had. So if you could just
Sure.
quickly, talk about that.
Sure. First, I just want to thank you for having me on. I always enjoy reading your content, and I think that you have been doing a good job for a long time of trying to connect the dots between different syndromic illnesses that are all neglected and that have so much shared pathophysiology and comorbidity overlaps. And so I just want to thank you for, you were giving me my kudos, but I really want to give it back to you because you've been doing that for a long time. And I think we need more of that. We need more people who can look at POTS and ME/CFS and long COVID and mast cell and fibro and say, how is this related and what's
Right.
different? Um,
Yes. Yes.
so
Thank you.
my own patient story is probably why I think that way, like you do, because like many of these patients, I checked off all the boxes on all of these conditions at some point in my illness journey. So going, I'll give you I don't know, I can't fit it into the elevator pitch, but I can give you the sort of short. Um, so 31 years old, I was pretty healthy. I was very athletic. I was working as a young attorney here in New York, doing litigation, which is a very, on your feet all the time, high stress job, and I thrived. I absolutely loved my work. I did mostly environmental law, some land use, and some corporate work. And I got a snowboarding concussion, snowboarding up in Vermont. And it definitely wasn't my first. I had so many snowboarding concussions that my snowboarding nickname amongst my friends was the bell ringer because I rang my bell so many times. I always blamed it on having a big Dutch forehead. But so, anyways, this one was particularly bad. I fractured my tailbone and had like a compressive concussion that sort of pushed my brainstem kind of like I felt like an olive sliding over a toothpick was what my brain kind of did to my spine.
Oh my gosh. Oh
And
my gosh.
immediately knew something was very wrong. And the next day, I tried to take it easy. When you've had concussions before, you can't give yourself a second concussion. You need to sort of chill and rest. And so my relaxing day on the slopes was to ski up the mountain on cross country skis rather than to snowboard down. That was like the level of physical activity I was doing at the time. That was my relaxing day.
Oh my
And I
gosh.
still didn't feel right doing that. And towards the end of the day, I had a friend with me who was actually an ER nurse, and she was like, I had my goggles on all day, so she hadn't seen my eyes. But when we took my goggles off, she's like, Lauren, you have a blown pupil. Like one of my pupils was really big and one was tiny. And she said, that's not good. I didn't know what that meant at the time, but I later learned that that's a sign of intracranial hypertension. I actually had like swelling in my
Um,
brain. So by the next morning, I couldn't even tie my shoelaces. I was really in a bad way. So my husband, we left the mountain and we went to an emergency room. that was my first physician encounter while having POTS-like symptoms. I had fainted multiple times in 24 hours. I was having really bad GI symptoms. You know, I was just really unwell. I was very shaky, that kind of adrenaline dump kind of feeling, and I don't know if I had official POTS in that moment, but I definitely had some autonomic dysfunction. But that wasn't in my vocabulary then. I was not a researcher or a patient advocate. I was just a lawyer who got sick snowboarding. I was like, oh, I have a bad concussion. I'm vomiting and having GI symptoms and all dizzy, and I have a bad headache. And went to the ER. And it was my first experience with gaslighting. The ER doctor said to me, it was January 2nd, and I was 31 years old. He said, I think you're just hungover because it's January 2nd. And I said, well, I'm beyond the age of hangovers. I'm not a college kid anymore. And it was 2 days after New Year's, and I only had one beer on New Year's Eve. So it wasn't that. And he said, okay, well, if you're not hungover, then this is just a panic attack. And I'm like,
No.
I'm not nervous. I'm in my snowboarding clothes. I was literally in my Burton snowboarding pants that were like pink camouflage pants. Like, who wears those in real life, right? Like, I was in my snowboarding clothes. I'm telling you, I had a concussion. I was knocked out, and you're telling me I'm just having a panic attack? So he did no physical exam, no orthostatic vitals, even though I told him I'd fainted multiple times, no imaging, no neuro assessments to see, what was going on with my weird pupil. And he just offered me a Xanax and a turkey sandwich. Or
Oh,
sorry, Valium. And I was already having trouble breathing, so I declined the Valium. I was like, I've never taken drugs like that before, and I know that they can slow down your breathing a little bit, so I don't want that. But I never turned down food, so I took the turkey sandwich and proceeded to puke up the turkey sandwich about 20 minutes after I ate it. So that clearly wasn't an effective treatment for my post-concussive, whatever neurological disaster I had going on. So I went home to New York and had to lay down on the whole car ride home. I slept for 2 days straight, which is probably not a good idea when you have a concussion, but that's what like my body needed. So I did.
mm.
And then I tried to go to work on Monday morning in my high heels and my lawyer suit, and I passed out in my office after lunch, which now I look back and I'm like, oh, postprandial hypotension. I ate something very high carb lunch. So I drove myself to the emergency room, which was probably a bad idea, but I certainly didn't think this is the first day of a lifetime of chronic illness. I thought, oh, I have a concussion. I better go get checked out at the ER.
Right.
Drove myself to the ER, passed out in the triage line at the ER. So they,
Oof.
and
Oof.
that started, well, actually that would be my second ER visit, but that started like 2 years of misdiagnosis. I was told everything from you have the croup, which is like a cough that babies get from an infection. I didn't have that. They thought I had celiac disease. They thought I had doctors suggesting this was just to get attention from my husband because I was 31 and hadn't had babies yet. And I was just doing this to get attention.
Um,
Which I laugh now because I'm like, what kind of woman, goes to the ER and vomits to get attention from her husband? Wouldn't you just go to Victoria's Secret if you wanted attention from your husband? Like, kind of think about that. Nobody, I don't know anyone that gets that kind of attention from their husband. So anyways, the story is turning longer than I intended, but
mm,
it was two
it's
years
fine.
plus of
It's
misdiagnosis.
fascinating.
Yeah,
Yeah.
I know that many patients in the chronic disease community have had a lot longer misdiagnosis than 2 or 3 years, right? Some people suffer for decades before they're properly diagnosed. So I feel kind of lucky in that it was only a little bit longer than 2 years. And in that 2 year window, I did get misdiagnosed with carcinoid syndrome, which is a type of neuroendocrine cancer. And I was
Oof.
actually admitted to a major New York City hospital and treated for cancer that I didn't have for 2 months inpatient. Um,
That's kind of amazing to me because you are in New York,
yeah,
where with, presumably some of the best medical care in the world.
yes.
And,
And I had
you're still having
all,
trouble.
yeah, I always point out, I had all the privileges going for me, right? I'm a wealthy, educated white woman who had good insurance. My uncle is chief of cardiology at a big hospital and
Well,
pulled all the strings he could and saw me himself and still couldn't figure out what was wrong with me. He, to
isn't
his,
that something?
I've had to forgive him for missing the autonomic part of the diagnosis. But anyways, nobody could figure it out. Finally, just by chance, I was covered in hives, as many of our patients can relate to, right? I was getting all these hives for like no reason. And so they called in a dermatologist to do a skin biopsy to try to figure out why I was getting these hives. So they biopsied a fresh hive right off my leg while I was in the hospital. And the pathology report came back and it said, well, there's no evidence of a mast cell disorder in this sample, but this patient has profound autonomic neuropathy. And I said, what the heck is
Oh,
that? Right? I didn't know what that was
no.
back then. So, like everybody, I Googled it, autonomic neuropathy. And somehow I landed on the Vanderbilt Autonomic Dysfunction Center website. And they list all the different autonomic disorders. And, when you read them for the first time and you're not part of this patient community, it's new, they all sound the same, right? And then I'm like, oh God, do I have this one, this fatal one? Oh my goodness, you read through all of them and then you try to dig deeper and read detailed journal articles on these different conditions. And by like 3 in the morning in the hospital bed, with having gotten the path report like dropped on my hospital desk, I decided I had POTS. And I was pretty sure it wasn't the fatal forms of dysautonomia like MSA. And I was like, I think I have this POTS thing. So I pulled all these journal articles on POTS and I called my husband at like 2 in the morning and I said, please print these out and have these at my off at the hospital for my doctor when he does morning rounds at 7 a.m. So my husband got up at an ungodly hour. We live 2 hours from the New York City hospital I was in. So he had to come in super early, give those to me. And I wrote in all the margins, all the notes that aligned with POTS, like my symptoms and the test results that matched and like the onset and stuff. And I gave it to this very senior neurologist who is the one that misdiagnosed me with carcinoid. And I said, I don't think I have cancer. I think I have POTS. And he said, don't go on the internet. I said to him, the least you could do after misdiagnosing me with cancer for 2 months is read the Mayo Clinic journal proceedings that I'm giving to you. I'm not giving you junk science from the web. I'm giving you journal articles. So he went home and he did it as his homework. He read all these articles and he came in the next morning. And I don't know if you're going to beat me out for this, but he actually said, holy shit, you have POTS. And it was,
Really?
I think the holy shit
Oh,
happened because first I was in the hospital for 2 months. Second, because it wasn't cancer, thank God. And third, because how could the patient figure this out when I literally had every expert in this hospital. They sent in endocrinology, electrophysiology, cardiology, GI, pulmonary, because carcinoid causes systemic effects, very similar presentation to a hyperadrenergic POTS phenotype. So funny enough, I've actually met other POTS patients who were misdiagnosed with carcinoid before they found out they had POTS. So not
wow,
the same one.
wow.
So the phenotype kind of overlaps. Um, so long story short, I ended up figuring out that I had POTS and getting it confirmed with actual orthostatic testing, and then tilt testing. And then pretty quickly from reading the POTS journal articles, I realized that POTS is just a syndrome. It doesn't explain the cause. And so why would this concussion cause this autonomic nerve damage? Like something seemed to be missing from my story. So I started going to different neurologists and saying, hey, can you test me for the causes of autonomic neuropathy? And I got a lot of doctors that were just like, no, just, really dismissive, including a major New York City autonomic center, dysautonomia center, that literally said, there's nothing we can do for you people, referring to POTS patients, and
Hmm.
refusing to test me for any of the known causes of autonomic neuropathy. So I ended
Oh,
up, it took a while to get to a place that was
jeez.
really interested in POTS. And I met an autonomic neurologist. He was at Cleveland Clinic at the time, and now he's at Case Western, Kamal Shamali. And I was very lucky to land with him. It wasn't by design. I just called a Cleveland Clinic, and that's who I landed with. And he said, okay, I'm going to run a bunch of tests, but I think you have Sjogren's syndrome as the cause of your POTS and your autonomic problems. And I had some sensory neuropathies too. So I was very skeptical because I had already been tested for Sjogren's with blood work at other centers and was negative. And he said, yeah, but some people are antibody negative on the blood work. You need a minor salivary gland biopsy to diagnose this. And
Right.
so we did that. And sure enough, I had Sjogren's. So, and I was so skeptical after being misdiagnosed with so much stuff for 2 years. I didn't even believe it. I was like, are you
Yeah.
sure? Because, you get misdiagnosed enough, you start to not believe anyone. So we took the lip biopsy specimens from Cleveland Clinic, and I actually had it sent to a Sjogren's specialty lab in New York. And they reran the assays and confirmed that it was in fact positive for Sjogren's. So I was like,
Oh,
okay, maybe we found something. And he said, okay, so now I want you to go on IVIG, and I think we're going to get you a lot better. And I said, okay, how do I get that? And he, at the time, was just leaving Cleveland Clinic to go to a different university and couldn't really manage it. So I had to find a local doctor here in New York willing to give it to me. And any patient who's tried to get on IVIG knows it's really hard to get insurance approval. It's really hard to find a doctor willing to help you. And it is not as easy as like taking a beta blocker. It's infusions, it's on an ongoing schedule. And so I ended up getting it approved, thank God. And I was on it for about 7 years. And then I switched to sub-Q immunoglobulin, subcutaneous, which is much easier on your body. If anyone listening has a choice between IVIG and sub-Q IG, in almost every case, I would say get the sub-Q if you can, because
okay.
it's fewer side effects. Um, so yeah, and I had every complication you could possibly have from IVIG, except for death. I had the complication.
Oh my
I
gosh.
had chest ports that had to come out with emergency surgery because it had slid into my heart. I had a blood clot in my PICC line, like every, thing that you don't want to happen when you're trying to get better. But eventually, the IVIG did have a beneficial effect. In fact, Court, I don't know if you remember this, but you actually interviewed me on my IVIG results like 10 years ago. You did a story when we first met. So maybe
Yes.
you
Oh, sure.
link to that in your in your article here. But
We had a big IVIG exploration, and I think I got quite a bit, probably got quite a bit of it from Dysautonomia International. But
yeah.
anyway,
So I am
it's from from the conference, one of the
yeah.
conferences.
Yeah. So in talking about it, I think it's really important just to take a step out of my personal experience. And I wish more of us as patients could do this. Thinking about your content, your own story is one thing, but trying to think about how does my story relate to Court's story, relate to the millions of other people who have this kind of stuff, right? And I think what I wish we could do as a research community and as patient advocates is focusing less on the diagnostic labels that we're given and focusing more on making sure we demand from the researchers that we learn the pathophysiology.
Right. Yeah.
We just sort of count up symptom profiles, or we do demographic studies, or we do heart rate and blood pressure studies. That's not really telling us like the ether, like what is the essence of this, right? Is we need genetic studies, we need immune biomarkers, we need metabolic markers, we need all of this. And if we find something in one of these diseases, we need to look for that something in the other diseases too, because it's almost
Right.
certainly going to be there.
Yeah.
Along my journey, I was diagnosed with ME/CFS. I was diagnosed with fibro. I was diagnosed with mast cell activation syndrome. Um, Not actual gastroparesis, because gastroparesis refers to the stomach being
Uh-huh.
slow. I had upper esophageal dysmotility. So my upper GI tract was more impaired, not my stomach.
You
Um,
had problems swallowing? Did you have problems swallowing?
Yeah,
Um,
swallowing, choking. I had aspiration pneumonia from accidentally inhaling my stomach contents multiple times. Yeah, it was not good. That's actually a known feature of Sjogren's. There are certain muscarinic
oh,
receptors in the esophagus, the muscarinic 2 receptors. And so I had pretty bad GI dysmotility. I had a 60-pound weight loss in just a few months, unintentional weight loss from the GI dysmotility stuff, but it wasn't technical gastroparesis, which is stomach uh, paralysis, for lack of a better term. Um, and so anyways, I had the small
and
fiber neuropathy, right? And I think we, as patients and as advocates, we get often we get diagnosed with the first one, and then when we get diagnosed with other stuff, we think it's related to the first. We think it's the first one is causing everything, right? Or
Oh, nice.
like patients who have migraine will also have autonomic dysfunction. They'll be like, migraine is the cause of everything, right? Or, and it's not, I'm not criticizing patients when I say this. I think it's natural human instinct when you don't have a complete understanding, because science doesn't have a complete understanding of what's going on with us, right? That we fill in a narrative that makes sense to us so we can explain it to ourselves and so we can explain it to our loved ones who are maybe doubting us or questioning us, and like have a framework for like, okay, what's going on in my life right now? What is this? So I wish we could, I'm not saying eliminate the diagnostic labels or anything like that, right? But really think about if you looked at these patients label neutral and you just put a whole bunch of them in a pathology study, I think they'd have more shared pathology than differing pathology. I think that they'd have a lot of small fiber neuropathy affecting the autonomic and sensory nerves. I think that they would have a lot of antibodies that disrupt the way the autonomic nerves talk to each other, the way the sensory nerves talk to each other. I think they would have a lot of inflammation markers. I think they would have a lot of metabolic abnormalities. And a lot of their symptom profiles are very similar too, right? So can we get to that point where the researchers are actually paying attention to what's happening in the other fields? I think as patients, particularly people who like follow your work and what we're trying to do with our patient community is like informing the sometimes I think the patients are actually more informed about what's going on in the other diagnoses because they have multiple diagnoses, right? Then like the top POTS researcher or the top ME/CFS researcher might not have the time to be reading about the new EDS genetic findings and the mast
Right.
cell biomarker findings, right? So sometimes we as patients are the first ones kind of connecting those issues and saying, I wish my doctor would read like all 5 of these papers on these different diseases. But the reality is research is very sort of micro focused on a specific diagnosis or even a specific theme within like within the ME/CFS world. You have certain people who are like the experts in this piece of it, right? And they
Right.
don't even know what's going on in the other ME/CFS research. So
Yeah.
I've been trying to get them to think about everything going on in the mast cell activation syndrome research and everything going on in the EDS research and everything going on in the POTS research. Like it's just not realistic. But I think that we use our conference to try to bring together researchers and patient activists from different disciplines to
Mhm.
try to have like a trading of the notes, sh sharing, what's going on in our different fields and trying to build collaborations amongst the researchers. I think for researchers to truly collaborate, they have to trust each other and they have to know each other. So
Mm.
they might have read each other's papers, if we can even get them to do that. They don't necessarily know each other well enough to be like, hey, let's work on a $1 million study together. You have to have a real relationship to do that. And so
Mm.
trying to physically bring them together, I always say the best research collaborations that I have seen happen at the hotel bar at our conference at midnight. Get the doctors a little drunk, they talk to each other, they make friends, and then they go off and collaborate on an ivabradine trial or something. But anyways, that was
Yeah.
a long-winded answer to your question.
I just have one specific question with regard to the swallowing problems. Did IVIG clear that up?
Yes. So my improvement on IVIG was, I would say it was sudden, but then also plateaued and then a slow improvement over time. So the things
Okay.
that improved quickly were primarily the GI dysmotility. That like after the first infusion, I felt significantly better on the GI motility issue.
Got it. Got it.
Um,
Oh my
I,
goodness. Isn't that something?
I had been on 2 liters a day of IV saline just to try to sit upright. And the first time I ever took IVIG, I never needed IV saline to help me with my orthostatic symptoms again, because when the GI motility improved, I could drink oral fluids.
All
Um,
right.
the,
Right.
the real reason I needed the saline is I literally could not drink like 2 cups of water. It was not happening. So, um,
Oh my
the
goodness. Boy,
slow
Sjogren's is really something, isn't it?
Yeah, so
Uh,
Sjogren's, I think there's a lot of undiagnosed Sjogren's within the dysautonomia community, not just POTS, but the broader spectrum of autonomic dysfunction within the ME/CFS community, within the mast cell community, within the fibro community, and now within the long COVID community. And it's if we can just briefly talk about that, because Sjogren's, it's not that easy to diagnose. First, you have a lot of doctors, even rheumatologists, who think it's not worth diagnosing it because there's no FDA approved treatment for it, right? So that's a dumb answer, but that is an answer a lot of patients are given by their doctors. There is no magical cure, but you certainly deserve to know if you have a systemic autoimmune disease. And
right, right.
in Sjogren's and like other, Sjogren's is a slowly progressive chronic autoimmune disease. It doesn't really go into remission. You might be able to tamp down the fire of autoimmunity for a while, but it's not going to fully go away. And so Sjogren's patients actually have a higher risk, a 40-fold increase in lymphoma. They have a higher risk of
Oh,
heart
no
attacks and
kidding.
yeah, heart attacks and strokes and
Ah,
miscarriage and other very serious interstitial lung disease and pulmonary hypertension. So if you have Sjogren's, even if there's no magical cure, you have to know if you have it because you need to do preventative steps to try to prevent all of those long-term consequences. Um, and so we've pushed, and there's some other patient advocates out there. I love Dr. Sarah Schaefer is actually a Sjogren's patient
okay.
who has a great blog called Sjogren's Advocate. You should maybe interview her sometime.
Yeah,
Ask-
yeah, 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 yeah.
She talks about the importance of knowing that the diagnostic criteria that are published for Sjogren's are meant to be research criteria. So they require positive SSA or SSB antibodies
Okay, okay, yeah.
or a positive minor salivary gland biopsy, which is how I was diagnosed. I am 14 years into Sjogren's and I still do not have the SSA or SSB antibodies. About 40% of Sjogren's patients do not have those antibodies. So most often if I'm talking to patients and they say, no, I already had Sjogren's ruled out, all they had ruled out was those antibodies. And that
Right.
doesn't mean you don't have Sjogren's. There's actually evidence from Johns Hopkins showing that Sjogren's patients that are younger and that are with a more neuropathic presentation, like you might see in an ME/CFS or dysautonomia person, right? That those patients are more likely to not have the Sjogren's antibodies. They're more likely to be the lip biopsy positive diagnosis. Another complication is if you ever chewed tobacco or smoked tobacco, you're more likely to have a negative lip biopsy result.
Hmm.
So
Interesting.
fascinating. This
Interesting.
is because of the nicotine in tobacco. The smoking and chewing tobacco are terrible for you for 4,000 reasons. There's no
Yeah.
debate on that, right? But they might reduce your risk of developing Sjogren's and RA. So
Isn't that something? Oh
yeah,
my gosh.
so you could actually have Sjogren's with a negative lip biopsy. It's supposed to be a clinical diagnosis. And there are new clinical trials happening in Sjogren's, so you do want to know if you have it. There's a lot of just like in POTS, there's a lot of off-label treatments already used in
Mhm.
Sjogren's. And there are specific treatments for specific parts of Sjogren's. So if you have severe dry eye, there are FDA-approved treatments for that. If you
Right.
have interstitial lung disease, there are treatments for that. So you really want to know. I would really encourage all of your listeners, like if you have any of these syndromic illnesses, really think carefully and talk to your doctor about getting screened for Sjogren's. Not because it magically cures your whole illness if you get diagnosed with Sjogren's and treated, but I am a perfect example of I could have been living bedridden for the rest of my life with POTS diagnosis. I
Right.
got a Sjogren's diagnosis. I got on the best treatment currently available for Sjogren's, and my POTS got dramatically, dramatically better. And my mast cell got better, and my PEM got better, and my migraines got better. Not cured. Like I still have all this stuff, but if you could take it from a 90% to like a 15%, I think most patients would be like, yes, I want to do that.
Oh my goodness. Oh my goodness. One of the reasons I grimaced at one point is that my mother, as I told you, my mother had Sjogren's,
Mhm.
and she also she also developed cancer. And
Lymphoma.
I'm not sure. I'm actually not sure, but yeah, there's really, it was just a long, slow process. And the steroids got to her and just all sorts of stuff.
Yeah.
So yeah, a lip biopsy is a good idea. It's a very good
Mm.
idea because I did test negative for the
The
antibodies.
antibodies.
So what about the connection between the spinal injury and the development of
Yeah.
Sjogren's?
So there's like many things that happens in these diseases. There's more questions than answers, right? We need so much more research, and it's so
Yeah.
underinvested in terms of research that I don't have the perfect answer for you. But I can tell you there was a study from Mayo Clinic showing that patients who had concussion had very significant autonomic dysfunction in the days following the concussion. Everyone concussed. They didn't have pot. This isn't a pot study. It's a
Mhm.
study on concussed people.
Right, right, right.
If you look at this, I can try to dig out the link for you. Basically, Mayo Clinic found that everyone after a concussion looks like autonomic. It looks like POTS. They have abnormal QSART. They have like a hyperadrenergic
Oh,
phenotype, right? And so most of these concussed people, in 3 months, they resolve. They're back to their baseline and they're okay. There's a subset of people who get concussion who just end up with a long-term chronic illness.
right, right.
Some of them get diagnosed, a lot of them get diagnosed with dysautonomia of some sort. Some of them get diagnosed with these other syndromic illnesses. And there's actually a study, Dr. Max Hills was the lead author. I don't remember, it might have been a collection of different research centers that worked on it. But there was a study showing that people who have concussion have a lifetime increased risk of all-cause mortality. So what does that mean? Obviously, we're all going to die at some point, right? But this is saying that they died earlier of whatever disease it was that they were going to die from. And so the theory behind this is that they have more inflammation. They have more
Yeah.
neurological deficit and more inflammation. So what we do know from other research is that autonomic dysfunction, whatever the initiating cause is, it doesn't matter. Chronic autonomic dysfunction is going to lead to chronic immune dysfunction. That is because your
Okay.
autonomic system is the
It
master
regulates the immune
regulator,
system.
is the master regulator of all of your
Yeah,
bodily functions, including your immune system.
right.
So I think that's a big area that needs to be studied in all of these syndromic illnesses, because every single one of them, the common thread between chronic Lyme and ME/CFS and long COVID and POTS and mast cell and EDS is that all of these people have autonomic dysfunction. They have some degree of autonomic impairment.
Yes.
And so this autonomic impairment is, even if your initiating factor wasn't immunological, like it's a concussion, right? Your consequence when you have chronic autonomic imbalance is that you are going to end up with some immune system changes. So we need to better define that. What does that mean? What does that look like? But there's actually a lot of research going on in established autoimmune diseases like rheumatoid arthritis and Crohn's disease, showing that those patients, when you look at them early in the course of their illness, they have autonomic dysfunction.
Uh,
And that when you treat them with something like vagus nerve stimulation, can actually take people with severe drug refractory rheumatoid arthritis, and it can put them into remission or near remission.
whoa, whoa.
I got
Yes, you're very big on vagus nerve stimulation. I do want to say that, I'm a twin. My other twin has been healthy.
Mhm.
I got sick when I was 20. And really, the one of the few things that's different between us is that I did have a concussion earlier,
Mhm.
and he did not. And I also got a email from somebody. I think it was like from a Colorado researcher or physician
Yeah.
who believes that he's found that people with traumatic brain injury had a greater risk of coming down with long COVID.
That
Um,
that makes absolute sense to me.
uh-huh.
I would love to connect with him if you want to introduce us. But
I will,
But
sure. Yeah.
there were other risk factors in the long COVID research is still coming out, a lot of it coming out. But some of the other risk factors for it are things that cause autonomic dysfunction. And that could be also during acute COVID, like what causes the severe acute respiratory distress, you know, and sepsis and things like during an acute infection, your autonomic system actually starts firing off a cascade of problems, and it gets to a point where it's like a melting point where like there's no return because it's just gone too far. So in the very beginning of the COVID pandemic, we were having conversations with David Goldstein at the NIH Autonomic Lab, and they were doing some in-house studies at NIH on acute COVID, severe acute COVID patients. And David and I, he officially pitched it to the NIH, but we had talked about trying to do two different interventions and then a combo during acute COVID, doing vagus nerve stimulation at the bedside to try to take someone from that pro-inflammatory state and crank up their parasympathetic tone to downregulate the inflammatory markers.
Yeah.
And then also benzodiazepines actually have a similar effect, right?
Oh,
So
interesting.
all of our patient community, I will raise my hand as well, get super pissed off if someone says this is caused by anxiety. You just have anxiety, it's nothing else, right? I don't think that's true. But if you do hear sometimes the mast cell patients will be given like a tiny dose of a benzodiazepine because it stabilizes mast cells. Well, it also tones down the sympathetic nervous system activity, which, you know, has some overall autonomic immune modulating benefits. So, you know, there's so much there that is not really well understood. There just hasn't been a huge amount of research. If you look even at the vagus nerve stim research that's happened, there are it hasn't been studied in that many diseases, and it's at the earlier stages of understanding. But that's good because that means there's room for opportunity for new indications and new trials and new thinking instead of saying, oh, it's all done and figured out already, you know. I think so. We're pretty excited. We have at our conference coming up, we are presenting one of our funded researchers, Dr. Katia Corrento at Wisconsin Children's, is going to be presenting new vagus nerve stim data in pediatric POTS. And she actually enrolled patients with GI dysmotility and POTS, most of whom also had EDS. And she had positive trial results showing that the vagus nerve stimulation actually helps these patients function better and feel better and improving their different symptoms. There was already a study that we funded from Humanitas University in Italy. They used a European device called NEMOS. So it's not FDA approved, but it's CE approved in Europe. And NEMOS was initially invented for patients with seizure disorders, but it's a vagus nerve stim and has a little, it looks like an old school iPod actually. And it had efficacy in reducing their symptom severity and improving their overall functionality and ability to be upright and mobile and, you know, living their life. So it's coming out. This is now the third trial that has been that has shown positive results. 3 different devices, 3 different trials, and 3 different populations of patients. Right, a group in Italy. There was adult POTS, the pediatric POTS EDS, gastro at Children's Wisconsin, and then also another researcher we had funded at University of Oklahoma, Dr. Stavros Stavrakis, has recently published using the Parasim device, which is it's got EU approval for dysautonomia, but it's not approved in the US yet. But the company is looking to do a US approval. They're actually going to be at our conference also at the end of this month. And they're presenting some research data that they have on using it, not just in POTS, but in broader like orthostatic disorder, dysautonomia. So
Wouldn't it have been great if Recover had swung out a little bit and then did a
so let's talk about that. So Recover did get vagus nerve stim applications.
yes,
At least one that I know of. And I was told by one of the PIs that they turned it down because it wasn't about POTS. They thought that vagus nerve stim would only help POTS because vagus nerve stimulation is known to lower the heart rate, right? But that's actually not why we use vagus nerve stimulation in POTS. To get the heart rate lowering effect, you would have to stimulate all day long. The way that vagus nerve stimulation seems to be helping POTS patients is that you stimulate just for a few minutes a day, and it's actually lowering your inflammation markers, and that's
Oh
the
my
lasting
gosh.
benefit, right?
Oh my goodness.
So if Recover had anyone with actual POTS expertise making decisions on grant applications, they would have known that, but they didn't. And so they turned down the vagus nerve stim application because it wasn't about POTS, which is dumb because even though we're the POTS organization, I would want this to be tried on long COVID, even if you weren't studying POTS in these patients. Like, I think
Sure,
it would be
sure.
helpful for long COVID. I think it would be helpful for ME/CFS, really all these conditions. And vagus nerve stimulation with a handheld device on your ear is a very benign treatment. If you
Mhm.
really, really overdid it and you jacked up the settings too high, you could cause an arrhythmia and too much of bradycardia. But there are certain devices that are meant to keep it within a safe stim window that you can't mess it up, basically. So I'm hoping that the research that we're funding and that others are starting to fund will become clinically available soon. Like, what's the delay? We have 3 different trials. Like, why is this not being recommended to all of our patients? And I think the
Right.
reason for that is there's no giant pharma company pushing it forward, right? That has a
Okay.
big marketing machine behind it. There's like several small companies. So I think it's going to be up to patient advocates to sort of demand this, and patients to actually go to their doctors and say, here's this journal article. Can you get me this device? I really want to try this.
Right.
And then we'll have to persuade the insurers to cover it, right? Some of these devices you can buy without insurance.
Mhm.
Uh, some of them are more expensive than others, but I think ultimately we're going to just need the clinicians to buy into it before we start seeing lots of clinical recommendations for this. Right now, most doctors are not, there are some doctors that recommend it, but the average Joe cardiologist that's diagnosing POTS is not going, let me recommend vagus nerve stim, right? At best, you might get a beta blocker, So
Right. Right.
we're
Yeah.
still trying to persuade them that it's more than salt fluids and exercise, that it's that there's actual medication that can help these patients too. So,
Right. Right. Um, uh, yeah, that seems to be something of a theme with Recover, not necessarily doing all their homework with regard to
yeah. Now
ME/CFS
I
and
was on,
dysautonomia.
yeah, I was on the clinical trial, the multiple planning committees for Recover.
Uh-huh.
And, it was good in that there was at least lip service to involving patients.
Right. Right.
So I was on the IVIG, there's a long COVID POTS clinical trial. They're calling it
Right.
Recover Auto, which right off the bat, the
Yeah.
patient said, that's a dumb name. Why don't you call it Recover Autonomic or Recover POTS? Because that's actually what it is. It's a POTS trial. And they didn't want to do that. NIH actually wrote back to us and said, oh, we're worried about calling it POTS because people might think it references marijuana. And we're like, literally millions of people have this diagnosis. And by the way, marijuana is not really a taboo anymore in most of the US, right? It's like, whatever. We probably
That
should
actually
have a
might
marijuana trial.
attract some interest, like,
We
oh,
probably should
POTS.
have a
What is
marijuana
it?
trial for long COVID, right? Like,
It's like,
but that's just how out of touch they are, that they
yeah.
don't even want to use the name of the indication that they're studying it for. So the IVIG trial that's happening,
Well, that's something.
they
Yeah.
ignored most of our recommendations and really intentionally kept the patients in the dark. They would finalize the trial protocol without even showing it to us, and then send it to us afterwards and tell everyone they got patient input on it. It was just, it was very clear that the patient engagement was for public relations purposes and it was not meant to be really meaningful. Now, there are some researchers within Recover who were genuine in trying to get patient input included. But I would say at the highest levels of leadership that was not really a priority. And if it was,
Yeah.
they would have, from the very beginning, we and other groups advocated for people who had decades of experience in studying post-viral syndromes like POTS, like ME/CFS, to be at the leadership level in Recover, not just to be on some side committee that had no real authority, but
Right.
to
Right.
actually be helping make the decisions on the study design. And that was largely ignored. you know? And so
Wow.
when you give nearly $2 billion to people who have no experience in post-viral syndromes, don't be surprised if what you get is something that's disconnected from what the patients actually need.
Do you
So
think there are adjusting? Do you see any signs
absolutely
of
not.
that? Absolutely not. I remember
I
you,
see a defensiveness. I see a defensive posture.
a defensiveness.
We've been in meetings with Senator Sanders and the NIH directors and all the institute directors involved in Recover. And it's just been excuses and defensiveness and not actually listening to our complaints. We're not complaining for the fun of it, right? Most
Right.
of the patient advocates who have raised concerns, and even the PIs, even the researchers involved in Recover have raised concerns internally. It's not just to hear ourselves talk. It's not. It's also pretty awkward when you are on the study committees to have to be the one criticizing it, right? Like it feels uncomfortable. But as patient advocates, sometimes you have to do that. Like you have to be uncomfortable with the uncomfortable. You have to be comfortable with the uncomfortable to advocate for your patients. And I don't see Recover changing the dynamics in any way. I see, if anything, they're closing rank and putting up the defensive barriers and saying, well, we did this because this was what we had to do, you know. Reading
Boy,
the
they're getting terrible press. You know, I mean,
yes,
it
and
doesn't seem
well,
like anybody is happy with
yeah,
them.
it's I think it's deserved. I think that there
An
was a lot of
enormous amount of
people
money.
who, yeah.
Jeez, it's just,
I think about if we had even 1/10 of that amount of money for POTS research or for ME/CFS research,
oh yeah,
probably could have figured out a lot more about these diseases by now. There was a lot of focus on, in the beginning, patient advocates were saying, you're not enrolling enough long COVID patients. You're not even enrolling at the beginning. They weren't even going to enroll the first wave COVID patients. And
I
those,
know,
it
I
was
know.
apparent to all of
Oh,
us in the patient
oh,
community that the initial COVID cases in like February and March of 2020 were the people who were like most likely to have long COVID. And that we
yeah.
didn't have formal data on that, but that was just apparent from being on our support groups. And initially they weren't even going to accept those people. So maybe that is a win that the patient advocates got, is that we demanded that they include some of the first wave people. But a
You
lot
know,
of I'll tell you what, they're more than 2 years, more than 3 years into the study right now. And autonomic testing, which is like the specialized testing you get at an autonomic research lab, autonomic testing has been recommended since the very first week of Recover, when they were having committee votes on what testing should be part of Recover. There was a committee of neurologists and psychologists. I was the only patient rep on the committee. And we got the committee to vote in favor of full autonomic testing for a subset of the study participants. Because there was going to be 14,000 participants. We don't have enough autonomic labs to test 14,000 people, right? It's just not enough. But it was for like a subset study. And we had multiple other committees of NIH reps and people from Mayo and people from Harvard, Stanford, all recommending to Recover to do autonomic function testing, because research outside of Recover has found that 70 to 80% of long COVID patients have dysautonomia, right?
right,
And
right.
that's including like pretty much all of the ME/CFS patients, plus other people who don't have PEM. So we push for this. It's 3 years in. They haven't done any autonomic testing yet at all. So it's like, so you basically
It's
you put in crap, you get crap out. That's the kind of crude way of talking about it. If you don't do the right methodology in the beginning, your results are not going to be super helpful. So now we're going to get data that doesn't mention anything about autonomic dysfunction. And then when patients go to get clinical care, their doctors aren't going to prioritize that because it wasn't in the Recover study. It wasn't in the Recover papers. We didn't really talk about it to the level that it was. So yeah,
it really is amazing.
yeah.
It's kind of amazing. It's like your worst nightmare. Like you think it's never going to happen, but
Yeah. We had
you
multiple
know,
papers where they were doing EHR research, electronic health records research.
right,
And so POTS, like ME/CFS, actually didn't have its own diagnostic code in the ICD
right, right.
until
Yeah,
October of 22.
yeah.
Right?
Yeah.
So there were EHR papers led by very brilliant data analysts, like people who do bioinformatics kind of research, right? And they would have a conclusion in their paper, oh, we found no POTS. There was very low rate of POTS in this study cohort, where there was no POTS in this study cohort. So therefore, that's not a part of long COVID. And I'd say, what year was your data set from? Oh, it was 2020. Well, there was no ICD code for POTS. No wonder you didn't see it. Like, why do I have to tell you this? Why is NIH not empowering people who have any clue about post-viral syndromes to be part of the research teams, you know? So we were basically playing defensive editing, trying to get these papers. Like if you didn't find POTS, that's okay, but you just have to acknowledge, because our data said there was no ICD code when we analyzed our data, like in that time frame, there was no POTS code.
Yeah.
So of course you're not going to find POTS there. If you looked at a ICD codes from October 22 moving forward, you would see a ton of POTS. And that's why there's actually multiple pharma companies now studying POTS, because there's an ICD code. They're seeing a high rate of POTS in the ICD, and they're getting into it. You know, I
But
hope.
and doctors are diagnosing it, so the word is getting out.
Absolutely,
POTS,
absolutely.
yeah, yeah.
And the studies that have observed long COVID patients and actually screened them for POTS and broader autonomic dysfunction have found a very high rate. There was actually a Johns Hopkins study that found about 30% of long COVID patients had a POTS code in their chart. And
Ah,
this kind of ticks off some of the MECFS, my friends, when I point this study out. And it was, you know, it was a study. It wasn't like we influenced it in any way. The POTS code was actually associated with a higher, like more patients had more severe disability. I think it was
yeah.
mobility disability and cognitive disability because of POTS than any other ICD code. MECFS was the second.
Oh,
You know, and so I think they're very much the same thing. Not exactly the same thing, but they're
no, no,
like
no.
cousins.
They're
They're
so
cousins.
they are close. And
Yeah.
you know, one of the I looked through the research studies, the research that you've been funding,
Yeah.
and the one of the things I liked the most was you're buying this transcranial Doppler equipment and
Yeah.
giving it to researchers, like 4 or 5 researchers.
Yes.
And I just thought that was brilliant
So
because that measures the blood flows to the brain.
yes.
Yes, yes,
So
yes.
we think, you know, a lot of people probably assume our organization is only about POTS, but that's actually not true. We fund research on other autonomic disorders.
Yeah.
But POTS is, if you go to one of the autonomic labs, like Dr. Novak's lab at Harvard, POTS is 95% of the autonomic patients that walk through the door have POTS. They don't have all these really rare, you know, there are tons of different types of dysautonomia, but POTS is like the biggest one. And
Okay.
given the size, the scope of the number of people who have it and the severity of the illness, it's received the least amount of funding compared to the other types of dysautonomia. But one of the things that happens a lot, and certainly to MECFS patients, is that you might have an autonomic problem that's nearly identical to POTS in terms of symptoms and disability and maybe the pathophysiology. But if you don't have that abnormal heart rate increase on the tilt, you're told nothing's wrong. Your autonomic nervous system is fine,
Oh,
right?
yes, yes, yes,
That's
yes,
not
yes.
true. It's just not the current tools we're using, the standard autonomic testing, is not capturing everything. So, as you know, there are multiple studies finding an abnormal reduction in cerebral blood flow when you stand up or even seated in many people who don't meet the POTS criteria. But POTS patients have it worse, like they have more cerebral blood flow drop. But you could still have this problem, maybe not to the severity that causes the tachycardia to get set off, right? So we think that autonomic testing needs to move beyond just looking at your heart rate and blood pressure measured at your arm. And I think there's a lot of researchers who get that and understand it. These autonomic tests that we use, most of which were invented in the 70s, and they haven't really changed. So, I mean, the ideal would be having some kind of blood-based biomarker, because I think that makes it easy to diagnose. And then, you know, there's a lot of doctors think it's real once it's on the LabCorp testing options, right?
Yes, yes,
But
yes.
but while we're waiting to find that particular biomarker, we should be measuring blood flow to the head. And so we're also pretty excited. I promise you, I'm not being paid to say this. I'm genuinely excited about it. The Stat Health ear device. Have you heard about this?
Oh, yeah, of course. Yes, yes,
So
yes.
they've recently rebranded to Lumia is now the name of the company.
Oh, is
And
that right? We did a thing on it about a year ago, and I haven't really, we signed up for it, but I
yeah.
haven't really heard anything from
So
them.
they have new research presented at our conference that shows that the blood flow to the head is actually a better predictor of dysautonomia symptoms than the heart rate in POTS. And so
Oh,
I think
I believe it. I believe it.
fascinating.
Yeah, 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 yeah.
And so having the transcranial Doppler devices available, and then eventually having these more mobile devices that are much cheaper than a transcranial Doppler, um, embedded into clinical care and embedded into research, I think could help us help a broader range of patients, not just the patients with the low blood pressure or the high heart rate, but
Right.
also patients who maybe their autonomic nervous system is working well enough that it maintains the heart rate, but not well enough that it's maintaining the blood flow to the brain the way and the organs the way it should, you know.
Right.
So there's so much. I know, like myself as a patient, when I was bedridden sick with this for years, I was thinking like, can I keep going? Like, this is so hard. I don't know if I could do this forever. And so I know there's a lot of patients that follow you and that follow our organization that are in that headspace that are just like, oh my God, I can't do this anymore. Like, this is so hard
Yeah.
and feeling
Yeah.
really desperate. And I don't want to sound cheesy in saying it, but I really feel like people need to cling on to some hope because there's so much research starting to happen. And I don't want to say, I can't guarantee anything, but I feel strongly confident that we are going to have better treatments for these patients in the not too distant future. And I wouldn't be doing this and getting up every day and busting my ass, like arguing with researchers if I didn't think it was worth it. So I think that, we have momentum. And as patient advocates, we need to just keep pressing the gas, pressing the momentum button, keep it going.
Yes, yes, indeed. Yes. So you mentioned a couple of things that are exciting. Is there anything else that particularly excites you that's going on in the field right now?
So I think that Cynthia Chabot at Vanderbilt has been doing some really cool research
Okay.
on glucose dysmetabolism in POTS patients.
Oh boy. Oh
And
boy.
so what we've known for a long time, patient anecdote, right, is that high carb meals make a lot of us feel worse. And
Mhm.
so patients on their own were trying keto, were trying Atkins diet back in the day, right? All these kind of lower carb meal plans. Subsets of patients would say this really helps me. Other people say, no, that doesn't help me. I need my carbs. But we had put advice on our website when we launched 12 years ago saying, try a low carb diet. FYI, there is no formal research evidence of this. It's not an evidence-based recommendation, but it's a patient anecdote recommendation. And if you try it for a month or two and it doesn't help, then you don't stick with it. It's pretty harmless, right? So we would get yelled at for that by doctors who would say, oh, it's not evidence. We said, well, we told people it's not evidence-based. So along comes Dr. Chabot, and she has a long history of studying diabetes and hypertension and sort of the autonomic problems of diabetes. And she said, I notice a lot of these POTS patients feel really awful after they eat. So she started
Yeah.
studying postprandial, which just means post-eating, right? Postprandial symptom exacerbation. And she found that when POTS patients have a certain amount of glucose intake, they release excessive GIP, which is a glucose, like a peptide that tells your pancreas to release insulin.
Oh
So they have
boy.
too much GIP. And interestingly, what releases GIP? Where does that come from, right? It comes from the K cells in the gut. Well, what stimulates the K cells? The sympathetic nervous system, norepinephrine. So POTS patients tend to have too much sympathetic nervous system activity. Some of them have too much circulating plasma norepinephrine. Some of them might have too much like intraneural epinephrine in your blood isn't necessarily the same thing as epinephrine in your norepinephrine in your nerves, right? It's sort of
Right.
But so they have too much sympathetic activation, and their K cells are releasing too much GIP after a carbohydrate intake. And then what happens is that over time, some of these patients are developing insulin resistance.
Oh
And
boy.
so that causes all kinds of its own problems. And
Yeah.
insulin resistance, like it's like pre-diabetes, right?
Yeah.
Pre-diabetes can actually cause autonomic and sensory neuropathies. So this could be a whole nother mechanism that is contributing to a POTS-like phenotype in a good subset of patients. And the other thing is that it's treatable. It has treatment pathways if you alter those GIPs. So a lot of these drugs that people are taking, like Ozempic and Mounjaro and all those things, those are regulating those various GIP, GLP, GLP-1, like there's all these different gut peptide, glucose peptide receptors that can be modulated. So there's also molecules that aren't commercial drugs yet that we can study to see if they can alter these pathways in a good way in POTS patients. So I'm really excited about that avenue of research. And because diabetes is so well funded, right? There's like an entire institute at the NIH for this. Dr. Chabot has been able, I believe, to get some larger NIH grants. And I think if other researchers catch on to this, that they will be there, there will be multiple lines of research in how to use that information to make better treatment recommendations for people. So in the short term, Dr. Chabot is now recommending POTS patients try a low carb diet. So now we finally have an evidence basis for what we've been saying for 12 years. And it's not just like everything. It is not going to be 100% of patients that say, I feel better from this. It's going to be a subset. But anyone who's been in this game long enough knows if we can find a treatment that helps 20% of patients feel 40% better, that's a win. We need as many different tools in the toolbox as possible to help our very complex patients.
Oh, that's so interesting. I've been wondering about glucose metabolism, and MECF, particularly, we're such a inactive community, and it just seems like we would be ripe for problems in that area. I don't know if anybody's looked at that, but
I think that some of that, if somebody did the work, you could probably link this somehow to the good work that David Systrom has been doing on the metabolic function at the sort of respiratory chain and all that stuff. I've actually sent, sometimes you hear about research that one person's doing and you say, oh, this kind of relates to what this other guy's doing. Let me connect them. Let me share their articles with each other. So we do quite a bit of that, trying to get people interested in collaborations and connecting the dots between their different research findings. I mean, maybe there is no connection, but sometimes you get a gut instinct that there is. And then when somebody eventually studies it, there is.
No kidding. Well, I guess one last question. What do you think of this attempt to create a center in the NIH that brings together, at least coordinates the research into all these different conditions?
We are 100% in favor of this, and we actually helped draft the legislation along with a bunch of other, patient advocacy organizations and alongside CFS and other groups that are involved. So the real problem is that when researchers, I'll give you a hypothetical, it's actually not a hypothetical, it's a real example, an example of what can happen to a researcher with a good idea. So there was a very noted researcher who wanted to do a long COVID dysautonomia study. So it's people who have dysautonomia following long COVID, and they wanted to study the cognitive impairment in these patients. And they wanted to do genetic assessments on these patients because they think they might have found a gene that increases your risk of getting long COVID dysautonomia. And they also wanted to study your immune function because they think that altering your immune function with a certain intervention would improve your cognitive status and improve your dysautonomia, therefore improving your overall long COVID, right? So this is a complex study. It's got genetics, immune system, long COVID, dysautonomia, brain fog. So they applied to NIH and they were told by whatever institute they applied to, NIAID is doing long COVID, heart, lung, and blood does dysautonomia, and NINDS does brain fog. And the researcher was like, okay, but these patients have all of the above, and I want to study this comprehensively. Where do they go? How do they get in the door? You know, this application was rejected without even being reviewed because it didn't fit some narrowly defined thing that each institute wants to see. So I actually brought this to the attention of some of the NIH leadership and said, you know, can you tell me where this brilliant application from a leading academic researcher at a huge medical center that gets a ton of NIH funding, they know what they're doing in terms of applying to NIH. How does this guy get in to get it? Where does he even submit this application? And I got sort of like a shoulder shrug, you know? So this is the problem. There's actually, each institute has a list of conditions they will accept applications on. That's not public info. Why not? If there's rules, why aren't we telling the researchers what the rules are, right? You need to know where to go with your ideas so you can be efficient and it takes a huge amount of time and effort and money. Staff time is money, right?
Yeah,
prepare an NIH application. So no one's going to do that if they're going to be given some crisscross directions on where, you know, you can't go here, you have to go there, you can't go there, you have to go here. That just really dissuades researchers from even bothering, right? So I think we need this NIH IACC, you know, Infection Associated Chronic Conditions Office, is not necessarily going to give us a huge amount of more money for these diseases. But even if we only had the amount of money we currently have, well, I mean, I hope we get more money for it, but even if we didn't, we could be using that money so much more efficiently if we were prioritizing what's most important in these conditions, what's shared pathophysiology. Like if we were doing a small fiber neuropathy study in long COVID, it would make sense to also be studying, well, which of those patients have POTS and which have ME/CFS and which have ES and which have mast cell. Like we're not doing that. Everybody's doing their own little segment of it. And there's no communication, not no communication, but there's minimal communication amongst the researchers. And so I think the patient orgs have latched onto this idea first that we can accelerate our discoveries and accelerate our eventual, you know, the end goal is to find more effective treatments, right? And so we can get there faster if we build upon the knowledge that we have in each of these conditions and if there's actual communication and intentional strategic planning. Because right now it's just a crapshoot. Like you go to one institute, you might get funded, you might not. You go here and you don't even know where to go for these applications. So yes, long answer. We are super in support of it. And we hope the whole patient community understands, like, no one's trying to erase any of these diagnoses. They're all their own independent diagnoses with their own advocacy orgs and their own leading researchers. But we're all in the same, I think the way to think of it, we're all in the same sinking ship. So we should be rowing together, right? The sinking in that we're not getting enough research funding. There's not enough pharma investment. There's not even enough researchers in the field. We need to get more people, more brain power into these fields. We need geneticists to get into it and more immunologists and hematologists and endocrine metabolic people, right? Like we just need more brain power here because there's tens of millions of these patients and they're just kind of, you know, we always have patients tell us, I get more information from my support groups than I do from my doctors. Well, it shouldn't be that way, right? And so we need more people to go into these fields. And it's actually hard to get them to go into it clinically because there isn't enough research. There's a lot of doubt and skepticism about these conditions. And then also just you'll have doctors say, well, there's no real treatment to give them, so why bother? Well, if we did more research, maybe we would have more effective treatments and that could attract more people to go into the field.
Has long COVID has the advent of long COVID, has that increased awareness of dysautonomia, and is it bringing more dysautonomia experts into the field? Are people like going into that field more?
I wouldn't say it's brought more experts. I think that it's taken our small number of existing experts and stretched them thinner than they were already stretched, because
Okay.
now they have all of their non-COVID patients desperately trying to get into their clinics. And they have now millions of additional people with long COVID dysautonomia trying to get into their clinics. I do think it has certainly led to more press coverage, talking about it. And there have been, it's just sort of a volume thing. Like the more people who are diagnosed with your condition, the more awareness there is. And
Right.
as I'm sure you know, like a lot of people who got long COVID were healthcare workers who were on the front lines and getting COVID over and over again. And there's a lot of healthcare workers who ended up with long COVID dysautonomia, ME/CFS, all the syndrome labels. And so that has raised awareness within medical circles in the most unfortunate of ways, because they got sick.
Right.
We are seeing more doctors who are coming to our clinician education courses or who are emailing us and saying, I need to learn what to do with these patients. I have these people showing up in my clinic and I don't know what to do for them. But they're not trying to become experts in it. They're just trying to figure out, like at the most grassroots level, like, what do we do for this patient? But that's a positive. We certainly need
Sure.
more doctors to want to know the basics at least. um, yeah, so there's some improvement, but I don't know that I do think long COVID patients are getting diagnosed faster with if they
Mhm.
have a certain form of dysautonomia, like if they have POTS or they have orthostatic intolerance, they're getting diagnosed faster because of the awareness around it existing in long COVID. But I
Mhm.
still think they're it's one thing to get diagnosed, it's another thing to get treatment from someone who actually knows what they're doing, right?
Right.
I
Right.
heard from a lot of long COVID patients who were told, you have POTS, all you need to do is salt fluids and exercise, right? And not even any details on how to do that, just a general sentence piece of advice, right? So we need clinicians to learn beyond that, that there's a lot more to offer. And then there's a lot of nuance to that advice. I mean, probably the
Sure.
biggest question mark is there. I don't know if you've seen, there's like ongoing debate in the literature, right? The POTS experts are always recommending exercise, and the ME/CFS experts are always going, oh, I don't know, maybe not, right? So we have tried in earnest to bring these folks together to talk about, what if you have both? What if you have been diagnosed with both? What do you do just from the most basic level as a patient? And we get a different answer from every single doctor we ask, right?
Oh my goodness. Yeah. Yeah.
So,
Yeah. Yeah.
can we get a meeting of the minds from experts and from patient advocates too, right? I think that it's important that we're not afraid to talk about this, because it is like $1 million question that we don't have great answers to.
Mhm.
The POTS research does show that pretty much everyone who does exercise gets not cured, but a lot better, right?
Mhm. Mhm.
The challenge is they weren't screening any of those patients for PEM. And actually nobody has ever studied PEM in POTS, like whether any of the patients have it, which we are sure that some of them do, because some of them have an ME/CFS diagnosis. So myself and Satish Raj and Kate Bourne at University of Calgary, we have this big POTS survey going on that is, it's been going on for about a decade now, and it has almost 15,000 patients in it.
Wow.
So we're going to be surveying those patients, who most of whom were in there prior to COVID, and asking them, we're just going to give them, not that it's the definitive answer on PEM, but we're going to give them the DePaul symptom inventory to
Uh-huh.
get a sense as to what percentage of them have some PEM. And then we've been encouraging researchers who study PEM, and particularly in the long COVID population, to screen not only for the PEM, but to screen for autonomic stuff too. Because what if
Uh-huh.
these are a piece of each other, right? Like
Right.
what if hypothetical, what if the autonomic dysfunction causes poor blood flow, which is driving a big piece of the PEM? Like if you have poor blood flow to your muscles, obviously they're not going to work right, So
Right.
so
Right.
I think David Systrom has done a little bit of that in his research. He's been thinking about that question, but I don't think his data gives us a definitive answer on it yet. So I think we need more research in that space for sure. So I would love to see the PEM research that happens in ME/CFS include autonomic dysfunction as part of the analysis. And I would love to see POTS researchers seriously think about PEM and start studying it in the way that the MECFS researchers are studying it. So we need them to trade notes more often.
Yes, 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 yes. That is so interesting because a study just came out in Gulf War illness, and they found no PM. Nope. And as an MECFS patient, I thought, well, of course they have post-exertional malaise.
Yeah.
But they didn't find, except in a few patients, a subset there was, and it wasn't a big study. It was 40 people. I think it was 40 people, but they didn't find post-exertional malaise. It was, so there's a lot to learn. There's a lot to learn about,
So
PM
years
and
ago,
all that.
years ago, I think it was Steve Vernino and Julian Stewart and a couple other well-known autonomic researchers did, I think it was a VA-funded study on Gulf War syndrome, and they found that these patients had a post-ganglionic autonomic neuropathy.
Okay.
And so why is a whole nother question. I don't think we know, right? But it was essentially the same autonomic small fiber neuropathy that you see in POTS, that you see in long COVID, that you see in MECFS, that you see in chronic Lyme. It was found in these Gulf War syndrome patients. So I think my hypothesis is that so much of the phenotype of these patients overlaps because they all have autonomic and sensory small fiber neuropathies, and possibly because they have ganglionitis, which we have no way of testing for clinically right now. So if you had autonomic ganglia damage right now, the world's best autonomic neurologist would not be able to diagnose it. It does not have a test. So
the ganglia are the nerve bundles.
Yeah, so you have different kinds of ganglia throughout the body, right? There's some in the brain and brainstem, like the basal ganglia and stuff. That's different. What I'm talking about is you have thoracic and cervical sympathetic ganglia that run along the side of your spinal cord like a chain of pearls.
Right. Yeah.
And then the parasympathetic ganglia are located like at the organ level, at the end organ. It's like small and it's there. So there's and then there's the dorsal root ganglia, which are the sensory ganglia. And that's at the back of the spinal cord. Dorsal, like think of a dolphin, like dorsal fin, it's along the back. And so there's actually research paper, there's autopsies published in MECFS finding ganglionitis in multiple autopsies of MECFS patients. They didn't specify whether it was autonomic or sensory ganglionitis, but it was most likely sensory because the autonomic ganglia are very hard to find. Most pathologists don't know how to find them. And the dorsal root ganglia are easy to find when you look at the spinal cord. I actually wrote to the autopsy authors and asked them which ganglia, but they didn't get back to me. And so there's research on ganglia pathology in chronic Lyme or post-treatment Lyme, whatever you want to call it.
Okay.
There's animal model evidence of acute COVID causing structural damage to the autonomic ganglia in 2 different rodent models of long COVID, of acute COVID, sorry. So a COVID infection would get into the nervous system and would attack the autonomic ganglia and structurally damage it. And they also found the virus replicating in the autonomic ganglia. So if that's happening in 2 rodent models, it's a very good chance it might be happening in some humans. So we've asked the RECOVER autopsy study to capture the autonomic ganglia. That was my major contribution to RECOVER, was demanding that they take autonomic ganglia and sensory ganglia samples from the autopsy study. And I did get that approved. So that's
a big one. That's a big one. Yeah.
But the caveat is, who's going to do the analysis? Who are they going to let have the tissue? Nobody involved in the pathology study has any interest in autonomics. So we actually had to teach them how to find the autonomic ganglia. So we connected them with some autonomic researchers who've done that before. So I'm not, I don't think we should count our chickens till they hatch, because I don't know if it'll ever hatch. But at least have the tissue. And then we have been working on some autopsy research in POTS. Nobody that's died from POTS, but from related conditions or surgical complications or whatnot. And I think that it's going to show something there too. So I really think the ganglia should be an area of future research.
Interesting. And the sensory ganglia, that sounds really intriguing, given all
Sensory.
the
Oh,
sensory and
right.
different
Also wanted to
symptoms.
mention, there was already, you're probably maybe familiar with this. I don't know if you wrote about this on your site. There was a fibromyalgia study where they did a serum transfer study where they took
Mhm.
serum fibromyalgia patients and they put it into mice, I believe. And it lit up the sensory ganglia. So the antibodies in their serum bound to the sensory ganglia in the mice. And
Wow.
the mice
Yeah.
developed a neuropathic pain condition, like a fibromyalgia-like condition from the blood of fibromyalgia patients. So I
Right.
connected with some of those researchers and said, can you repeat this study with pot serum and look at if it binds to the autonomic ganglia or the sensory ganglia? Because even though we define POTS as an autonomic syndrome, the vast majority of POTS patients have sensory neuropathic pain too. Um,
Right. Right.
it's most common when people have an autonomic small fiber neuropathy, they almost always have a sensory small fiber neuropathy too, and vice versa. If you have a sensory small fiber neuropathy, you probably have an autonomic small fiber neuropathy too. The challenge is most patients never get tested for both. So, so you might have someone that says, "Oh, I have sensory neuropathy," and we're like, "Well, what about autonomic?" And they go, "I don't know, I never had that tested." You know.
Do the small fibroneuropathy biopsies, do they differentiate between the two, or is it
So some of the labs do, and many of them don't. The most common testing is intraepidermal nerve fiber density, i.e. NFD. That is
uh-huh,
only looking at the sensory fibers. That's the very surface level of the skin.
surface,
A
right?
little
Right.
bit deeper, like another millimeter deep, you can capture the pseudomotor fibers, which they call SGNFD, sweat gland nerve fiber density. And so there's only some labs that do that, not everybody.
And all this damage would be due to some inflammatory or autoimmune response that is
I think
attacking
that's
these.
a big research question.
Uh-huh.
Why do so many of these people have small fiber neuropathy? So I think probably the leading hypothesis is that it's immune mediated, but there's
Right.
definitely other things that can cause small fiber neuropathies, and ischemic, lack of oxygen, lack of poor blood flow to this part of the body could cause a small fiber problem. Reperfusion injuries can cause a small fiber problem,
Oh,
metabolic problems, diabetes, prediabetes, insulin resistance like problems, acute viral infection can damage small fiber, all sorts of stuff can damage your small fiber nerves, particularly because most of them are unmyelinated or thinly myelinated. So they don't have that fatty protection around them that your large fiber nerves have.
mhm,
So they're
mhm,
more sensitive to damage. But the good news is small fiber nerves can actually grow back,
mhm.
especially when you take away the offending, whatever was causing the damage in the first place. So my own case, my small fiber nerves grew back. We have pre and post IVIG biopsies. Before IVIG, I had an 85% deficit in my pseudomotor density. I basically had 85% less fibers than I was supposed to have, which is a pretty bad neuropathy. And when I redid them after 6 months of IVIG, when my symptoms had improved pretty dramatically too, I had high normal nerve fiber density. It wasn't even like mid-range normal, it was like high normal. So,
Wow.
so you know, but it's still not perfect because my QSART is still abnormal. So QSART is not the density of your nerves, it's how well your nerves are functioning. So I think they
Okay.
grew back, but they're still a little wonky because my QSART is still abnormal. Um,
Right.
anyways,
Right.
but I think, this is all stuff that needs a ton more research. Like we need millions of dollars to figure out all of this. Like we could probably talk all day about all the things that are not studied in these diseases that we need to study.
Yeah. 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 So many possibilities, which is, I mean, it's nice that there are so many possibilities, and hopefully, we'll get the funding over time. Uh,
Yeah, I think we need to talk about these possibilities. Like a lot of researchers, they hold their research ideas close to the vest. They don't want to tell anyone about their ideas. I'm the opposite. I'm like, please, someone study the ganglia. I think there's something there. I don't care if it's my idea or not. Just steal it and run with it. So because, we don't have enough people in this field. And if we can
Mhm.
inspire, if someone reading your site says, oh, I never knew about this ganglia thing, and they say, oh, I'm going to study this, or I'm going to talk to my PhD friend and get them to say, great, we need all hands on deck. The more people involved in these fields, the better. And I just want to thank you again for constantly trying to build the connections between the different research worlds that exist, the little silos we have.
Oh yeah, it's fascinating. It's just fascinating, the overlaps. And I don't know, it's like a burgeoning big field. And
Yeah.
hopefully it will show up that way at some point.
Yep.
Maybe we'll have a new discipline or something. I don't know.
I
But
think
anyway.
neuroimmune dysfunction broadly, is
Mhm.
should be a field. Even like established autoimmune diseases, there's over 100 like defined autoimmune diseases. They've been historically underfunded and neglected, and these are things that we know the biomarkers, we know there's actual organ damage and all that. And so those patient orgs actually got together and formed a coalition. It used to be called the AARDA, American Autoimmune Disease, I forget the name, but now it's called the Autoimmune Association. So they
Okay.
banded together, all of these different autoimmune disease nonprofits and researchers got together and pushed the NIH to create an autoimmune office at the NIH. And so I think that's what we're trying to do in our, we could be like the Neglected Syndromes Coalition or something. That's kind of a negative sounding, but and I also think it's important to recognize while POTS is most often post-infectious or particularly post-viral, there are lots of people who might have these things not from viruses or
Mhm,
pathogens.
mhm.
And
Right,
it's
right,
actually
right.
just as important to study them because how did they end up with the same clinical phenotype as the post mono person, right? If you have
Right,
post
right.
EBV, ME/CFS, how do you have the same clinical picture as someone with post concussive POTS, right? And so
Right.
understanding those pathways is actually going to be important to understanding, to finding new treatments for everybody.
Which is why we need to all get together. Okay, okay. Well, thank you so much. It's
Sorry, I
been
talked too much.
no, not enough. I just learned so much.
The excessive norepinephrine just keeps coming out.
Okay, keep it coming. Yeah, yeah. Well, yeah. Well, thank you. I mean, it's great to have somebody who's so curious and creative and is trying to put the pieces together and taking the long view. And I think that's what we really need in these fields. So I'm just so happy that you showed up. I'm sorry you had to get ill to do it, but I'm just so happy that you showed up and have, you know, and created dysautonomia and are part of the solution. Yeah.
Yeah, I hope so someday. We're trying to get there. Well, anyways, thanks again to you too. Same thing. And I feel like, maybe we need to start like a patient conference for patient advocates and scientists to come together once a year, or maybe even not once a year. Maybe it's like every 2 years or something, because all of us are so bandwidth limited in our own health issues and trying
Yes.
to run different organizations and do policy work and stuff. But I think it would be really great to actually have physical sit down with each other and talk about like what's the leading stuff going on in each of these little subfields. And I don't say little subfields in any derogatory way, but we are like relative to like breast cancer, we're all pretty little fields, right? We
Right,
have
right,
small
right,
funding,
right.
small amount of researchers. And just get like the highlights from each disease area and actually get the researchers and the patient advocates to sit down and say, okay, what did we learn from this that we can use over here with these people? And how do we really foster those in-person connections so that the researchers will start working together more? I think really what's happened is because we're all operating in a grossly underfunded silos, right? It's
Hmm,
like a
hmm.
scarcity mindset. It's like people saying, well, if we work together, we might lose money for our disease, right? And I think that it's hard to overcome that. But if you can, and you can say, we're all underfunded, but when we work together, we're louder and bigger, and we make more of a political impact as a group rather than as individuals. I think the patient org leaders understand that. That's why we've had this pretty great coalition that's formed.
Yeah. I think it's becoming obvious to many that we need to work together. And I think that would be really energizing as well, if you could, get people together and see what's happening in other fields. And I mean, I would love to know more about what's happening in post-treatment Lyme disease. And so, yeah, well, let's have it happen. Yeah.
Let's do it. All right, you and I planning the conference. Let's go.
Here we go. It started here.
I'm not kidding. I'm going to email you after this.
Okay. All right. Do it. Bring it on. Yeah. Okay. Well, thank you so much again. And yeah, good luck with everything. And once again, I've learned an awful lot. So thank you.
Thank you.